You can hear me?
Yep, we can hear you.
Okay, thanks everybody for coming on. I appreciate it. Hopefully this will be educational and helpful. And I tried to really answer a lot of the common questions I get in the office in this lecture, in addition to some education on the topic. So what I'm going to be talking about today is the concept of rapid recovery after hip and knee replacements. What makes a difference? What doesn't make a difference? So hopefully this will be helpful. Just a little background on me. I'm a native of the Philadelphia suburbs, so I'm a homeboy. I went to college at Princeton University. I did medical school and my orthopedic training at the University of Pennsylvania. I then did an extra year of training at the Rothman Institute for joint replacement. And I took a job here immediately afterwards, and I'm going to start my 14th year of practice in August. So I've been around for a little while. I have lots of gray hairs, unfortunately. My practice involves the evaluation of hip and knee pain in patients who may benefit from joint replacements, evaluation of patients with problem hip and knee replacements who may benefit from revision joint replacements. My offices, as was mentioned, are in Washington Township, Marlton, and King of Prussia. And my operative facilities include Jefferson Health, Washington Township, Thomas Jefferson University Hospital in Philadelphia, and Jefferson Health Cherry Hill Surgical Center. We'll talk a little bit about outpatient surgery in my talk, and I am doing some outpatient surgery. So as an introduction, there are a lot of terms that get discussed in the press, on commercials, amongst patients, even amongst physicians, and a lot of them are overlapping and they can become confusing. You hear the concept of minimally invasive surgery, small incision joint replacement, anterior hip replacement, quadriceps sparing knee replacement, or I don't cut the tendon, robotic joint replacements, and outpatient joint replacements. And all of these are kind of pointing towards the concept of, obviously, patients and physicians alike would like the patients to get through a joint replacement as painlessly and as possible, and also with the least stopping of their function over time. So they want to recover as quickly as possible so your function is not affected for too long. The goals of joint replacement are elimination of pain, restoration of function, avoid complications, and do things in a way that's going to optimize implant longevity. If we can achieve these goals optimally, then that's really a successful joint replacement in my mind. So common questions: what does minimally invasive surgery mean? How much does small incisions play into minimally invasive surgery? When the whole concept of minimally invasive surgery started many years ago, the first iteration of it was small incisions, and that actually turned out to not make a very big difference in patient recoveries, but that was kind of the first iteration of minimally invasive surgery. The next concept is how much dissection is done in the deep space. Do you cut muscles? Do you cut tendon? More recently, robotics has come up with a topic, and there is some confusion and even some false advertising about robotics enhancing the recovery. And robotics actually inherently have nothing to do with the recovery. We'll discuss that later. And then you have this concept of same-day surgery, which at the end of the lecture, we'll come back to that. And does that mean a rapid recovery? Well, to a degree it does, and to a degree it doesn't. So we'll review these concepts in the setting of answering the question, what really makes the difference in enhancing the recovery? What it boils down to is, in terms of the incision length, I mentioned that was the first iteration of minimally invasive surgery, but really what the incision length boils down to is the goal is to minimize pain, but we find that actually the length of the incision really has no bearing on the recovery or the level of the pain that the patient has. One of the members of our group many years ago did a study where patients were randomized to a small incision or a bigger incision. Their incisions were kept covered, and they asked questions about pain and recovery, and we found no difference in the length of the incision in terms of the impact on the recovery or their level of pain. Cosmetics certainly can play a role, but Dr. Rothman himself used to say, if you keep the incision small, then you stretch out the tissues and the incision becomes under tension and you end up with a small, poor-looking incision. So even cosmetics isn't 100%, a guarantee with the small incision. So what is a rapid recovery? How do we define it? Well, first of all, you want to minimize postoperative pain. Obviously, if a patient has a lot of postoperative pain, they're going to have difficulty mobilizing. So you want to minimize postoperative pain. You want to minimize the time spent in the hospital. Some people, think of the concept of a rapid recovery. Well, how quickly am I going home? And to a degree, that makes a difference. Going home versus going to rehab. Obviously, a patient going to rehab and spending a week in rehab, I'm not sure that I would qualify that as a rapid recovery. Most patients enjoy going home. We find that patients do better when they go home. So in my mind, part of a rapid recovery is going home rather than to rehab. The time to independent ambulation. How long are you using your walker? How quickly are you graduating to a cane? And how quickly do you return to nothing? Along those lines, how quickly do you return to work and other functional activities? And what is the time to a full, painless, and functional recovery? And so answering the questions about time to independent ambulation and, one of the important concepts here is I actually, in my practice, see more of a problem of patients moving a little too quickly with the recovery rather than those, spending too much time on their walker and complaining about not recovering quickly enough from a functional standpoint. So, after a hip and knee replacement, there's obviously, in some cases, bone healing to be done, bone to the implant, and in some cases, soft tissue recovery, in all cases, truthfully. And if a patient becomes mobilized too quickly and does too much too soon, that can actually cause more swelling, more bleeding, more pain, and that can actually paradoxically slow the recovery down. And so, again, I'm seeing more of a problem of patients moving a little too quickly. And I find myself at the 4-week point after surgery having to slow more patients down that I'm encouraging people to graduate from their walkers. And so all of these things put together really do play a role in rapid recovery. So what about, and rapid recovery does, involve a multimodal approach. All of those concepts that I just reviewed act in unison. And when all are done correctly, then the patient gets an enhanced rapid recovery. There are preoperative factors that influence all those topics. There are surgical factors, and there are postoperative factors, and we're going to review those at this point. Patient factors that influence the recovery. Well, the combination of their height and weight forming their body mass index makes a difference. Their age, their pre-surgical functional status, their medical comorbidities, whether or not they're taking narcotics before surgery, and their extent of the arthritis in as far as how that influences their pre-surgical function, that influences things. So on the right, we have two cartoon pictures. The top is a heavier grandmother who walks with a walker at baseline. And on the bottom is a young, healthy runner. And you can imagine that even if you do a surgery exactly the same way in these two patients and keep everything else the same, that the recoveries are inherently going to be different. And my point is that patients recover at different rates. Every patient is an individual, and every patient has to be, treated as an individual, and every patient should think of themselves into it as an individual rather than comparing themselves to other patients who have gone through the recovery. And, I do my best to counsel patients on what to expect with their functional recovery. For example, if a patient is using a walker for 6 months before a hip replacement, I tell them that they're probably not going to be getting rid of their walker within a week or two like most patients do. Managing expectations, again, tailored to each patient. I ask patients to establish a support network to plan for the postoperative period. Again, I like my patients to go home, and it's great for them to have somebody to stay with them or for them to stay with if they're living by themselves. We do discuss what to expect in terms of the level of pain and the early functional goals. Their length of stay in the hospital. Most patients go home within 24 hours. There are some times that for various reasons, patients have to stay in a little longer. And again, many of our patients now are going home the same day. The goal of getting home after surgery rather than going to a rehab, that's something I feel strongly about in terms of getting that rapid recovery. Reaching functional milestones. How long until you should expect to get off of the walker? How long until you get to expect to get rid of the cane? How long till you're riding a bike and walking longer distances? We review all of that beforehand so a patient has the correct expectations going into surgery. We also provide videos, pamphlets, and other educational tools to enhance the discussions that we have in the office. Pre-surgical physical therapy, or sometimes referred to as prehab, the concept here is muscle atrophy and general deconditioning can happen due to pain, stiffness, and disuse of arthritis. And the thinking here is that if you go to therapy beforehand and improve your strength and improve your range of motion and improve your general conditioning, then maybe that will make the recovery easier. You have to be a little careful with this concept. While sometimes pre-surgical therapy can be helpful, especially in terms of familiarizing patients with the postoperative therapy protocols, training them to use crutches or a walker, you have to be a little careful about not doing too much therapy beforehand with good intention of trying to gain strength and function to prepare for surgery and end up just causing more pain. The less pain a patient has going into surgery, in my mind, the better they'll do in terms of their recovery after surgery. So here it's finding a fine balance between your pre-surgical activity level and minimizing pain before surgery. What are the surgical factors that can influence a rapid recovery? Well, one of the things we do is neuraxial anesthesia or spinal anesthesia. This avoids the patient waking up and immediately having pain from waking up from a general anesthesia and having no other, numbing agents in order to give them pain relief. It gives the patient hours of pain relief after surgery when they're waking up in that period. As the spinal is slowly wearing off, the patient can then slowly get more and more pain medicines in order to have a nice transition from the pain relief of a spinal to the pain relief of medications. You avoid the side effects of general anesthesia, such as the sore throat, nausea, in many cases, lightheadedness and other things that can affect your early recovery. And it actually decreases the risk of blood clots to have a spinal or neuraxial anesthesia. There are some cases where a patient cannot have neuraxial anesthesia. Some neurological disorders would stop a patient from having that. In addition, patients with, a lot of hardware in their spine or spinal stimulators, might not be a candidate for a spinal. We usually leave that for a discussion between the patients and the anesthesia team. But in general, the anesthesia modality of choice is the spinal. The length of the incision, many patients equate the incision length of the speed of the recovery, but in the end of the day, for the most part, it involves mostly cosmetics. The downside is if the incision is small, the surgeon can sometimes have trouble seeing exactly what they're doing, and that can influence the position of the components, which can actually influence the longevity of the implant. In addition, as mentioned before, Dr. Othman used to say a small incision is usually a poor appearing incision. So by no means do we make the incision bigger than we need to, but we don't strive to make the incision small because we're really not achieving any goals by doing so, and there are some downsides. And again, the study I previously mentioned shows that recovery time actually is not changed by the incision length. What about the way that we go about doing surgery? Well, for hip replacements, there are many ways to do the hip replacement once you make the incision. The three main ways of doing it, which I've actually trained in all three ways, is through the front or the anterior approach, which is probably the most heavily advertised approach, the anterolateral approach, which is from the side, or the posterior approach, which is from the back. One of the themes of my lecture here is that you have to be a little careful with things that are advertised, because just like anything else in life that's advertised, they only tell you the good things and not the bad things. And the truth is that all of these different ways of doing a hip replacement have pluses and minuses. And, each plus and minus has, maybe some individual patients are better off with certain approaches because of the balance of the pluses and minuses. But in the end of the day, there are many studies that show that at 6 weeks after surgery, you cannot measure a difference no matter how you do the hip. And so while there may be some subtle and small differences in the recovery within the first few weeks after surgery, at 6 weeks, there's no difference. And again, each plus of these approach comes with minuses. With the knee, the most heavily advertising thing is, quote, we don't cut the tendon, or quadriceps tendon sparing surgery. And again, you have to be a little careful with this. This is not a new way of doing surgery. This is a way of doing surgery that really has been around for many, many years. The Rothman Institute actually wrote some of the first papers on the quadriceps sparing knee. And again, there are many studies to show that the way that you subtly change the way that you do the surgery from the standpoint of whether or not you go between fibers of the tendon or cut across the tendon or cut across the muscle do not impact the recovery. And so again, beware of the advertising with this. Does the deep type of exposure influence the speed of the recovery? The answer to that is at 6 weeks, certainly not. There may be subtle differences earlier. There are some studies to show that there are subtle differences earlier, and there are some studies to show that there are not. But we're talking very small differences that are even hard to measure from a clinical standpoint. What about pain management? Well, there are several concepts here, and this is a critical part of a rapid recovery, because no matter how you do the hip and no matter how you do anesthesia and no matter how much counseling a patient gets before surgery, if their pain isn't in control, they can't have a quick recovery. So preemptive analgesia means we give patients pain medications before surgery to pre-treat the pain, to load their body with the medication beforehand so that it's in their body when they're going through that initial recovery. We typically give a combination of anti-inflammatories and Tylenol. And during surgery, we give a pretty heavy-duty IV anti-inflammatory. Intraoperative analgesia, obviously the anesthesiologist is giving you medication through the IV, but as mentioned before, the spinal is very helpful in enhancing the immediate postoperative recovery. Local adjuncts. You can do localized injections. You can do peripheral nerve blocks provided by the anesthesiologist. You can add things to the spinal. In some cases, you can do an epidural. And in other cases, you can leave a catheter in the joint. That's not done quite as commonly now. That was, maybe 10 years ago, that was popularized, not used as much. One of the keys is to avoid narcotics by IV, especially with the pain pump. That's what a PCA is. It's a pain pump. And we find that patients on a pain pump have a lot of highs and lows of pain, which makes the early recovery more difficult. So we try to focus on oral medications. And what we do is we use a combination of medications: Tylenol, anti-inflammatories by IV and by mouth, oral narcotics. Some surgeons use neurological pain medicines to help with nerve pain. And then we also minimize side effects by giving medications to minimize nausea, minimize lightheadedness, and such. So you do get a lot of medications in the postoperative period, and these really help a lot in terms of your early recovery. Next, you want postoperative early mobilization. We get patients out of bed the day of surgery and walking the day of surgery. We avoid tubes and lines. We typically do not use catheters in the bladder, and we typically stop using the IV as soon as possible so that a patient's not hooked up to an IV pole, because if you're hooked up to an IV pole, it doesn't encourage walking. We do early physical therapy, and we try to get patients to reach their milestones as soon as possible. By milestones, I mean a certain distance walking and going up and down stairs. Where do patients go after surgery? Well, the choices are home or to rehab. The vast majority of our patients go home, and nowadays, the only typical patient that goes to rehab is an elderly patient who lives by themselves, who frankly just won't be safe at home. And it's not that they need the rehab, because the rehab really doesn't provide anything that you can't get at home, but it's not generally considered safe to send a very elderly patient home by themselves. When that's deemed an unsafe situation, sometimes rehab is the option. So in summary, we use a multimodal approach to rapid recovery. Pre-surgical, post-surgical, and post-operative factors all play a role in this. This is multimodal. And the surgical factors are actually far less important than all of the other factors that we discussed. Common questions that are asked: the anterior hip replacement, heavily advertised. I actually know how to do it. When I started practice, I was doing it. Many of my partners do it, and it is a very fine approach. It's a good way to access the joint. It's a good way to accomplish the goals of surgery. There are some potential downsides to it. Like with any incision, you can get some numbness around the incision. There are some reports of a higher risk of certain complications with this approach. There is also a learning curve, so I'd be aware of a surgeon who's just starting this approach. But if this is something you trained with and that you're very good at as a surgeon, it is a very fine way of doing the surgery. Cutting the tendon or not cutting the tendon in knee replacements, that is truthfully mostly false advertising. One way that you can get a patient to come into the office, or sometimes even implant companies advertise different ways of doing surgery, but not cutting the tendon or quadriceps sparing surgery has been shown in multiple studies to not make a difference in the recovery and not make a difference in the long-term function of a patient. And it does, to a degree, in many cases, compromise the surgeon's ability to do a good technical job and do the good construction works that they need to do. So that's that. Robotics. So robotics is one of the newer things in joint replacements. And what robotics involves is getting a pre-surgical imaging scan of the patient's, usually the knee. It's also done in hips, but it's usually the knee. And based on that, they put that information into a computer where you can do some planning in the computer. During surgery, some extra incisions are made where pins are placed, and then tracking devices are put on. And basically what's done is the computerized plan is executed by a robot holding the saw. And, this is a technology that is being improved. One of the analogies I use to patients is it's similar to the technology of a self-driving car. And there are some roles for it. And there are some times that I use computer guidance in joint replacements when it's needed. But by no means is robotics going to enhance your recovery, improve your long-term outcome, or make a huge difference otherwise. So again, you have to be a little careful about things that are heavily advertised for that reason. Not to say that robotics are the wrong thing to do. Many of my partners, again, use it, and I think it is a fair way of doing things. Again, it has its upsides and downsides. Same-day surgery. So this is something that is more commonly done across the country, and the Rothman Institute is also doing more of it, going along that trend. And I have started doing outpatient surgeries myself. This morning, in fact, I did a knee replacement in a patient. Within a few hours, they went home. And, you may say, well, why do same-day surgery? And, one thing is patients don't like to stay in the hospital. Nobody really likes being in the hospital with the beeps and the bells and the whistles and staying up at night. And, often patients just don't do well in the environment of being in the hospital. And so going home the same day is somewhat appealing. So what do we do differently to allow a patient to go home the same day? Well, for the most part, it has been shown that doing same-day surgery in a surgical center is actually more successful than doing it in a hospital. And the reason for that is because at the surgical center, everything is geared towards getting the patient home. Whereas if you do surgery in the hospital, many of those patients are going to be in the hospital a day or two. And so they're getting the same resources and services as the patients going home the same day. And so in a surgical center, for example, the spinal anesthetic that's used is quicker acting, so it wears off a little quicker. The physical therapists in the facility all know that the patients are going home the same day. So as soon as the spinal wears off, they're there working with the patient immediately, avoiding delays. And specifically for knees, there are some extra things that the anesthesiologist can do, including nerve blocks, that can help enhance the early pain control. In addition, patients typically need to be motivated to move forward with outpatient surgery and be on board with that. Otherwise, if there's a thought in their mind, maybe they'll stay an extra day, they're less likely to do well with outpatient surgery. And so, same-day surgery has its benefits. It's something we're doing. You do have to be a good candidate for it. If you do outpatient surgery or try to do it in the wrong patient population, they can have, higher complication rates. For example, an older patient who lives by themselves is probably not a good candidate for outpatient surgery. A patient with a history of, significant heart disease or had a heart attack or stents, less than a year before surgery, probably not a good idea. And so this is something that's being done. Some patients are a good candidate for it. And when the surgeon and patient are both on board with the concept of outpatient surgery, it is certainly an option in many cases. This is a funny cartoon that one of my patients gave me, saying, I can't say I'm entirely pleased with my hip replacement. I thought it was pretty clever. So that's the end of my lecture. Certainly, I have plenty of time to answer any questions. I'll leave it up to the moderator to kind of filter out the questions that were asked in the question and answer.
Yeah, so I'll start with a couple of questions I got via email, and then I'll jump into the Q&A. This question is, I had a total knee replacement almost 16 weeks ago. My knee still feels sore at times, especially when I wake up in the morning and when I've been sitting for a while. Is this normal? And I have periodic pain on the side of my leg and was told it was from the tourniquet. Is this normal? And finally, my hamstring feels tight. Is this normal?
So I will say that all of those comments that you made can very well be normal after surgery in the early postoperative period, and I would consider you still within the early postoperative period. Swelling can be normal. Pain in the thigh around the knee can be normal. A sense of clicking can be normal. Difficulty with stairs. A sense of warmth from inflammation. Now, just hearing this question online, without evaluating you in person, I can't say for sure that there isn't something else going on. I will give that caveat. So if you're concerned, you should probably talk to your surgeon about, whether or not you need to be evaluated. But everything that you just mentioned very well can be normal after a knee replacement at 14 weeks.
Great. And this was one more question from the email. I developed swelling in my knee about 14 weeks after surgery. It spread to my leg and foot. The doctor advised compression socks and raising my leg. I did both and the condition improved. What causes the swelling, and can I expect it to happen again?
Good question. So swelling just happens because the knee is inflamed, and swelling can flow down the knee towards the foot, make the foot swollen. The more activity you do, the more swollen it gets because your knee gets unhappy. And so, often patients do have waves of swelling as they do in more and more activities. In addition, some patients have veins and a lymphatic system that doesn't work perfectly, and those patients can be more prone to more dramatic swelling. Lastly, the skinnier your leg is, the more pronounced swelling becomes. And so if your leg is particularly skinny, you may notice more swelling than somebody whose leg is more average in size.
Thank you. And Dr. D, if you want to show your face while you're talking, or if you just
sure,
want to
I'm
put
sorry.
the presentation
Yep, I forgot
back
that
up.
I was
No, that's okay. That's okay. It'll be nicer to see your face, I think, on the playback.
There we go. You're able to see me?
Yeah, there you go.
Okay, great.
So how soon can you safely go back to bike riding after surgery?
Good question. So for both hip and knee replacements, especially for knee replacements, riding a bike can actually be a very good activity to encourage range of motion. And, I encourage patients to get on a stationary bike or a recumbent bike soon after surgery. Often physical therapists will incorporate as part of the physical therapy for knees. Typically, our hip replacement patients don't do formal physical therapy because it really doesn't make a difference in the recovery. But with knee replacements, some surgeons use formal therapy and others don't. I tend to do it because I like my patients to have that personal trainer. But the bike can really encourage range of motion. So I encourage use of a bike or a stationary bike, truthfully, within a few weeks, usually between the 2 to 3 week point. Riding outside, my only concern is the risk of falling or getting sideswiped by a car. So, once a patient is comfortable to do that, usually somewhere between the 4 to 6 week point, that I'll encourage that.
Great. And this question asks, do you personally do the surgery, or do you only oversee the procedure and rely on a team?
Right. So much like building a house, one person can't do it by themselves. So we have a team. The team typically involves the surgical technician who organizes and hands us the instruments, the circulating nurse in the operating room who organizes the paperwork, does the computer things, make sure everything is in order, and is a set of hands that is not sterile so that they can do things involving touching things that are not sterile. We have a hook holder typically who is an assistant who is sterile in the operating room to hold hooks and to help retract. And then we have a first assistant in order to, again, help hold retractors, cut sutures, give us direct assistance. In terms of the first assistant, I personally have a physician's assistant who works with me directly. He both helps with holding instruments during surgery, and he's the seamstress that closes skin. He honestly closes skin much better than I do. I get more compliments about his closures than I do about the way that the x-rays that I do look. And so we do, in some cases, have residents observing and participating as the assistants. But the answer to your question is I am doing the surgery with first assistants.
Perfect. I was told that until I have constant pain in my knee, until it wakes me up at night because of pain or limits my activities, I'm not yet a candidate for knee replacement. Yet my knee has caused deformity in my lower leg, and my knee has near bone-on-bone friction. Your thoughts on waiting or not? If I had the knee replaced now, maybe it wouldn't improve my quality of life.
Good question. So this is a pretty complex question. The question is, when is it time to proceed with a knee replacement? And you have to meet a few criteria to being a candidate for a knee replacement. You obviously have to have x-rays that show severe arthritis, which it appears that yours do. You have to be a good candidate medically otherwise, which I will assume that you are. Obviously, I don't know the details, but I'll assume for the sake of argument that you are. And then you have to have a level of pain that is currently affecting your quality of life. The answer to that question is truthfully different for every patient. And so, I one time had a patient who I tell the story to patients all the time, who came in with a very bad looking hip on x-rays. And I asked him, wow, that much hurt. How much pain do you have? And he said, I have no pain whatsoever. I said, well, why are you here to see me? And he said, I can't hunt. And I said, what do you mean you can't hunt? And he said, every time I go try to hunt, I have to stop after a short period of time because my hip won't let me do it. It didn't make sense to me, but after testing and counseling, we ended up doing his hip replacement. Well, I ended up, forgetting the details of him. But when I saw him 6 months later, I said, how's your pain? And he said, my pain, I never had pain, but I can hunt again. And so my point of the story is sometimes patients' perception of pain and how it affects their life is different than others. And so, rather than saying how much pain that you have, I ask patients, how much does it affect your quality of life? How often do you think about your knee? How often does your knee stop you from doing things that you want to do? And when you look yourself in the mirror and say, I can't live with my hip or knee another day the way that it is, then you're ready for a joint replacement. Another analogy I use is how tall is the grass before you cut it? If the grass is really tall, that first cut of the summer always looks beautiful. But if it's not that tall and you put the work in of cutting the lawn, often you say, gosh, I put all that work in and it doesn't look very different. And so, that's an individual question, answer that you try to work out with the doctor that you're discussing with the joint replacement. And between the two of you, you try to figure out if the right's time. But the truth is, outside of developing a severe deformity, if you feel like your quality of life is not diminished as of yet, there's really not much of a downside of waiting. And you can always do the surgery later as long as you're not developing a severe deformity or severe stiffness.
I love that analogy. I'm going to lock that away and use it for something about the grass. That was really good.
Right.
Moving from cane to walking independently after hip surgery, when would this be expected?
Again, that is different for every patient. I have had patients that within a few weeks are walking independently, and they're typically the ones in the office where I'm trying to ask them to slow down a little bit, because they're the ones that will then tell me the next week they did 18 holes of golf walking. And then you have patients who are using the walker for 3 months because they had been using a walker for 3 years before surgery, and it's going to take them more time to develop the muscle strength to get rid of their walker. And so I would say that the typical answer I give is a week or two with a walker, 3 to 4 weeks with a cane. But every patient is different. Some people get rid of the cane sooner, and some people get rid of it later.
Following a hip surgery, how frequently or do you recommend an X-ray to ensure there are no issues with the joint material?
So we get an immediate post-operative X-ray, and while you're in the hospital, I see my patients typically at 4 weeks, but somewhere between 2 and 4 weeks, you'll be evaluated by your surgeon. And typically we get X-rays at that point. And then typically at the 6-month visit, we get new X-rays. Obviously, if there's any question with the way that the X-rays look at any point in the process, we may get more frequent ones based on that. But it's typically the immediate post-operative X-ray in the hospital. 2 to 4 weeks from surgery, you get an X-ray, and then 6 months from surgery, and then typically every 2 to 3 years after that. Once it's healed, then you're just monitoring for wear, like you monitor for your tire being worn out.
Great. What percentage of hip replacements use an anterior hip replacement? I know you talked about this, but they're wondering if the percentage is growing.
Yeah, I think a lot of growth happened with that, mostly due to advertising, truthfully. Much of that growth is done. I don't know what the recent statistics are in the United States, but, I'll tell you within the Rothman Institute, there's probably just about an equal number of doctors who do them the 3 ways. And so again, what you have to be careful with, and again, if there was one perfect way of doing a hip, and the Rothman Institute is the world's leader in research and joint replacements, we would all be doing it that one way that's better. The fact that we are all doing things differently tells you that there isn't one way that's way better than other ways. And again, each has their pluses and minuses.
Perfect. I was told I could be a candidate for a partial knee replacement. Do you do those?
Good question. So a partial knee replacement, what that means is the knee has 3 main parts: the inside, the outside, and under your kneecap. And if you have arthritis in more than one of those parts, then you need a total knee replacement. If that patient were to get a partial knee replacement, you would by definition be leaving arthritis behind. When patients have isolated arthritis in one of the 3 compartments, they may be a candidate for a partial knee replacement. I do evaluations of all patients who have, arthritis, and we make decisions on what's best for the patients based on their evaluation. And so that's a hard question to answer without actually seeing X-rays and looking at the individual situation. But I would say in most cases, a patient ends up needing a total knee replacement because those patients with real true isolated arthritis in one compartment are not as abundant in those with more than one compartment.
Perfect. Knee replacements, say this person's asking after age 90.
I'm sorry, say that again.
Is there an age limit for candidates for knee replacement? This person saying after the age of 90.
Yeah, there isn't a specific age cutoff where we say, well, now you can't have surgery. I start to get nervous based on age alone when a patient's over 80 because of risk of stroke and heart issues. Now, we certainly have you do a thorough medical evaluation beforehand, but obviously an elective major surgery is more risky if you're over 80. Although truthfully, our studies show that patients in their 80s do actually quite well as long as you do a careful pre-surgical workup. Above 90, I am hesitate to operate on somebody unless they are in such bad shape that life's not worth living, because, although we do patients over 90 who break their hip all the time, doing an elective surgery on a patient like that, I mean, honestly, most patients, there aren't many patients who see me above 90 with severe arthritis, because most of them have already had their joint replaced if they need it. But I do occasionally see them. And I will say that if a patient is over 90, but they look like they're in their 70s, they're healthy, and their medical doctors support proceeding, that's not something I would necessarily be against. I would just have a long discussion making sure the patient understood the risks.
Great. And how long does a knee replacement typically last? And after that time, what would happen next?
So the longevity of a knee replacement and a hip replacement is variable. I would say the average for a hip and a knee, for a knee replacement, is somewhere between 15 and 20 years. Although the older you get it, when you have it done, it will probably last longer, because it's like buying a car that you're not putting as many miles on. The younger you get it, the more wear and tear on it, it might not last quite as long. So the number I go by is, in general, studies show that if you're over 60 when you get if you get your knee replaced, that it's more likely to last you the rest of your life than it is to fail in your lifetime. Hip replacements are a bit more durable because of the technology being a little better, and also it being a more simple joint. And so, modern hips look like they're probably going to last 40 to 50 years. We've only been using them for 20 to 25 years. And in that time, it looks like they're holding up great in that time frame. Now, hip or knee replacements can fail in a year and they can last 90 years. There's some variability, but in general, the average for a knee, I would say, is 15 to 20 years, and longer for a hip.
And we have a couple of travelers in here, so they're just asking about activity on travel. How long after a knee replacement would you suggest being able to travel to Europe? And then, is 9 weeks too soon to go on a 5-hour flight with 4-hour drives between tourist sites with Jeep rides through a desert?
Good question. So the best information we have regarding the safety of travel after joint replacements comes from a study in Chicago, where there was a surgeon there who was big into marketing, and he heavily advertised his minimally invasive surgery. This was many years ago. And so patients would actually fly into Chicago to have him do their joint replacement. Now, he wasn't doing anything drastically different than other surgeons, so they probably could have done the same thing locally, but the advertising can be very strong. And again, you have to be careful with advertising, but he published a study at one point showing that patients that flew to Chicago, got their surgery, and then flew home soon afterwards did just fine without complications. What I usually tell patients is, if it were my hip or knee, I would wait 4 weeks before flying, like to, Florida or somewhere locally. I would wait 6 to 8 weeks to take a 5-hour flight, like to Mexico or California. And I would wait closer to 10 to 12 weeks to taking a fly overseas to Europe. And, there's two factors here. One is sitting on a plane for a long time, you're sedentary. I worry about the risk of blood clots, which is usually the first 6 weeks or so after surgery. I usually, really 4 weeks is the big thing, is the big time frame. And secondly, God forbid you were to have a problem, you don't want to be stuck in another country 5 weeks after surgery now with a problem, a broken bone, something like that, and you're stuck in a foreign country dealing with, how am I going to get this taken care of? So I usually go by 4 weeks locally, 6 weeks, for a 5-hour flight, and overseas for a much longer flight, I would suggest 10 weeks or so.
Okay, great. How common is trouble with bending your knee after a replacement?
Good question. So physical therapy is helpful after a knee replacement. Some surgeons don't have their patients do physical therapy. But the bottom line is, moving your knee is critical after surgery, because you don't want it to get stiff. You don't want scar tissue to form. So in general, the risk of a knee becoming stiff and remaining stiff so that it's a problem, say 8 weeks after surgery, is somewhere between 1% and 5%. And if that happens, we usually bring a patient back to the operating room just to simply bend their knee under anesthesia to break up that scar tissue. And so, usually we can predict the patients that are going to get stiff. For example, if you've had issues with scar tissue with prior surgeries, if you had prior knee surgery and you had stiffness with that, or if you had a knee replacement on the other side and it got stiff, then you're at a higher risk. So usually we can predict those that are going to have trouble with stiffness. But the short answer to your question is, trouble to the point that you need intervention is somewhere around the rate of 2%. So not very high.
Here's an interesting question. Because I got spinal meningitis after an epidural giving birth, should I be concerned about getting a spinal?
You know, that is truthfully a better question for your anesthesiologist. My answer would be it probably would not be an issue because you don't have an active infection while you're getting it, but I'm truthfully not the most qualified person to answer that question. That would be a discussion between you and the anesthesiologist.
What percentage of people need both hips replaced if the cause is arthritis?
Truthfully, I don't know the statistics of it. I would say that patients who have arthritis in one knee are much more likely to have it in the other knee, and the true is with the hip. I'm not sure that there's an association with other joints aside from patients with bloodborne arthritis, such as rheumatoid arthritis. But obviously, there is a genetic component to arthritis. So if you get arthritis in one of your hips or knees, you are much more likely to get it in the other hip or knee than the general population. Many patients who come to see me with severe arthritis, who we discuss and schedule a joint replacement on, already actually have some signs of arthritis in the other side. That's very common.
And then I just have a couple more. These are recovery, back to activity type questions. How long is physical therapy? What is the typical recovery for an average healthy person? And what is the typical gain of range of motion for the functionality after knee replacement?
Okay, the first question was, sorry, can you repeat the first one?
Sure. How long is PT? I'm assuming for a knee, but
so
I guess
we don't do formal PT for hips. For knees, I don't like my patients to start PT the first week after surgery because it can just increase the swelling and pain and have a patients take steps backwards. So you get PT in the hospital. They typically show you basic exercises and make sure you can do stairs before you go home. The first week, I encouraged range of motion under your own power with the goal of keeping pain in control and balancing the pain that comes from moving the knee with the gaining your range of motion. Then you start formal therapy. And as soon as range of motion is clearly not going to be an issue, a patient can stop therapy. So it can be anywhere from a week or two to a few more than that if you're having some problems with stiffness. The typical recovery for a hip and knee replacement is a week or two with a walker, a cane for 4 weeks or so, 3 to 4 weeks to drive, 4 to 5 weeks to get rid of the cane, 6 weeks for the majority of the recovery to be done, and by 3 months, you're really done fully recovering. And then did I miss a question in there?
No. Oh, there was the second part of that. What is the typical gain of range of motion and recovery level of functionality?
The answer to that question, truthfully, depends on your pre-surgical range of motion. If you have a good deal of stiffness pre-surgically, you are likely to get some stiffness post-operatively. My ultimate goal for a knee replacement is fully straight to 120 degrees of bend. Some people get a little more than that. Some people get a little less than that, depending on what the pre-surgical motion was. But 0 to 120 in my mind would be the average goal.
Great. This is a good question. Following a hip replacement, what self-imposed PT do you recommending walking? And how do I know if I'm pushing too hard? I think that's a good question.
So the way that you know that you're pushing too hard is if you're causing yourself more soreness and discomfort as well as swelling. And what is the self-directed PT? I honestly just encourage patients to walk. Walk with the walker. As you feel strong enough, get rid of the walker and go to a cane, and then get rid of your cane to nothing. Walking is the best activity. As soon as you try to focus on strengthening certain muscles, that's when you cause more inflammation and more pain, which actually sets you backwards. So it's letting it rest, calming down inflammation, and walking. That's the therapy.
Okay, just the last few questions. If you have knee replacement before hip surgery, does progress to walking independently take longer? This person is 12 weeks post-hip surgery. In
general, the knee replacement is a little bit of a more difficult recovery than a hip replacement for a variety of reasons. And so, the time that it takes to walk independently depends on a lot of things. My general experience is the time to a functional recovery, meaning getting rid of your cane and walker, is somewhat similar between hips and knees, but it's a really patient-dependent thing. For example, if you had a knee replacement before your hip, let me read the question. I'm sorry. So if you already had your knee replacement and then you're having your hip replaced, your recovery time should not necessarily be longer than if you hadn't had your knee replacement. In fact, it will probably be shorter, because if you have arthritis in your hip and knee, you get your hip replaced, let's say, that recovery is going to be somewhat slowed down by the fact that you have arthritis in the knee. When you then go to get the knee done, now you don't have a bum hip anymore. And so your recovery, you may find to be a little bit easier from a functional standpoint. So certainly a patient with arthritis in multiple joints can recover slower than those with only in one joint because you're not walking on, arthritic joints during the recovery.
Perfect. How do I avoid hip dislocation?
So the risk of hip dislocation has really decreased over the years, no matter how you do the surgery. There are some ways of doing the hip where the risk is a little lower. And sometimes surgeons ask patients to practice what are called hip precautions, meaning avoiding certain extremes of position. With some surgery, hip precautions actually don't make a difference because the risk of dislocating is already so low. And so what I would say is the simple answer to that question is being smart about not trying to stretch your hip out and not trying to go to an extreme of motion. For example, avoiding positions where your knee gets close to your chest or avoiding dramatic crossing of the legs. That can help you avoid dislocating. But the truth is, the risk of dislocating a hip after surgery is certainly less than 1%.
How long are restrictions on a lateral hip surgery? Maybe that's bilateral.
Right. The lateral hip, I'm assuming they mean the lateral approach to the hip. So the lateral approach to the hip happens to be the one with the lowest risk of the hip popping out. There was a landmark study that came out maybe 20 years ago where patients were randomized to hip precautions, meaning avoiding certain positions, versus no hip precautions. And we found no difference in the risk of the hip popping out. So specific restrictions actually aren't required when you have the hip done through a lateral approach. But truthfully, many surgeons who use the other approaches don't hold restrictions either, because with some improved technology over the years, improved implants and such, the risk of the hip dislocating is pretty low.
Awesome. I think the last question is, what kind of exercise should I do before knee replacement?
So keeping your knee as mobile as possible within the limits of your pain, staying as active as possible within the limits of your pain, they're the big things. If you were looking to strengthen your quadriceps muscle before surgery, your best bet is to do exercises where you just have your leg straight and you lift your leg up, because that strengthens your quadriceps without loading the knee. So something like a squat would be a big no-no. That strengthens your quad, but it puts a lot of force on the knee, and it's likely to just make the knee hurt a lot. And so the key is to do as much strengthening and improve range of motion and improving your function as you feel, as long as you're not causing yourself severe pain.
Okay, perfect. I think that was.
I saw another question there. How long before I can golf? And that's a pretty common question, actually. So I'll answer that. Typically, what I tell patients is by somewhere between 4 to 6 weeks, I would encourage them to maybe go to the driving range and start with a small bucket. If you tolerate that, the next time you go to a medium bucket and then go to a large bucket. Usually by the time you're right around 8 weeks from surgery or so, you can try playing a few holes, maybe even 9 holes with a cart. And then certainly by 3 months, you can do golf without restriction. And then I see another question there. How long after a knee replacement can I go to the gym for muscle rebuilding and strengthening? When you're talking about muscle building and strengthening for the joint that was replaced, I would recommend waiting at least 3 months, because if you try to strengthen it too much, you put too much load on the hip or the knee, and that can, make the knee more inflamed and make it hurt more. After hip replacement, is there anything I can do again? I actually don't pose any specific restrictions on my hip replacement patients after surgery. I have patients who have run marathons and triathlons. So, the question is there anything I can do? Maybe they meant, is there anything that I can't do? But to answer that question, I don't make any specific restrictions. Doubles tennis, I see a question here. It depends if it's a hip or a knee. I would say just about all hip replacement patients, unless there's other issues, can do doubles tennis. And I would say most knee replacement patients are able to play doubles tennis, but that's less of a guarantee. Swimming after a knee replacement, I usually ask patients to wait 8 weeks after surgery for a hip or a knee before you submerge. I see that was corrected. Is there anything I can never do again? No, there isn't any specific restrictions on a hip replacement. Knee replacements are much less likely to be able to run. I'm not going to say it's impossible, but certainly it's not expected.
All right, so we have no open questions. I do want to say in the email that everyone got, you have my contact information. If something else comes up, you can send me a message and I will get it answered for you. If you want to schedule an appointment with Dr. Deirmengian, my number is also in there, and you can call me and I can help you get set up with an appointment.
Great. Thank you very much for coming. I appreciate it. Thanks for helping coordinate too, Kristen.
Yes, thank you so much. Thank you, everybody. Good night.
Have a good one.